Vermont. I'm the Dean of the School of Public Health here at Yale University. I want to welcome all of you in the Winslow Auditorium this evening, as well as those of you joining via live streaming. Thanking in advance our speakers who joined us this evening on short notice. My only duty this evening, other than to quiet the crowd, is to welcome this evening's moderator and introduce him. Dr. Saad Omer is director of the Yale Institute for Global Health. He's an infectious disease epidemiologist, a vaccinologist, and a physician. He's also professor of medicine in infectious diseases at the Yale School of Medicine. He holds the Susan Dwight Bliss Professor of Epidemiology and Microbial Diseases at the Yale School of Public Health, and also has a secondary appointment in the Yale School of Nursing. We are lucky to have Dr. Omer here. He is the inaugural director of our Yale Institute for Global Health, and without further ado.
Thanks, Stan. And besides being the Dean of the School of Public Health, we at the Institute for Global Health are privileged to have a true pioneer in global health, Sten, as one of the deans here at the Dean of the School of Public Health. And he's one of the founding fathers of the Institute for Global Health. So it's a privilege to be here and talk about this important emerging public health issue. And just to outline what we will be discussing, we'll be discussing the academic response of the various parts of the university, the university and the hospital as an institution which is located in New Haven, etc., and interacts with its communities. It is a part of it, but our focus here is an expert panel covering various issues from an academic and research perspective. And there have been other panels in the past few days and in the last week or so in the university, but this one has a focus. We want to do a comprehensive focus on a few issues ranging from epidemiology to communications to virology to some aspects of preventive measures and the public health response, etc. Before I start, I will start with a few overview slides, and then I'll welcome our distinguished panelists, and most of the session will be based on questions and answers. I'll go through a couple of rounds of questions from the panelists, then we'll open this forum for discussion. We have a really good and solid, rich base of faculty and students who have a lot to contribute, so please feel free to contribute. I want to thank, in terms of organizing this, specifically YSPA's Department of Epidemiology of Microbial Diseases, especially Albert Coe, who was very instrumental. I don't know where he is. I don't see him right now, but I'm sure he'll come. And he was instrumental in choosing the panelists, etc., and was very helpful in organizing this. I also want to thank Global Health Justice Partnership, Gregg Gonsalves, who was one of the panelists, and Amy Kopczynski, and a few others who have been really helpful. Yale is very privileged to have long-standing collaborations with our colleagues in China, and there are a lot of efforts going on. Especially, for example, there's a coronavirus working group focusing on a few research questions, which is very driven by our Starlight Fellows. And I would encourage colleagues with connections to China and of Chinese heritage to contribute in today's discussion. So without further ado, I will start with my introductory slides. So we know that the initial cases were identified and reported from Wuhan city in China. And it is an unfortunate aspect that some people call it a Wuhan coronavirus. I'm very uncomfortable, and a lot of us are very uncomfortable labeling this virus with a place and adding to a little bit of culture of stigma that sometimes evolves. But it was identified. It's appropriate to say it was identified initially in that place. It is now, as of this morning, spread from it's spread to 28 countries. And this is a map. But there's also some sobering reflection on the status of the outbreak in the sense that the major chunk remains in China. And the major chunk remains in mainland China. There have been over 28,000 cases reported. There are model-based estimates that go much higher than that, but in terms of reported cases are 28,353, including, unfortunately, 565 deaths. And that's a very sobering reflection on the status of the outbreak. But when it comes to emerging diseases, it's not just that we are concerned about what has happened so far. And can you imagine that during the holidays, most of us hadn't, yes, I was looking at the reports, there were emails circulating, in early January, starting in late December, there is something percolating, but we didn't know about this major outbreak. Certainly, it wasn't common knowledge, it wasn't a major concern, and how quickly this disease has become a major concern. We think the family of viruses it comes from, it sort of tells us that it is likely to have the more permanent host as a bat virus. When you use icons, sometimes they look closer to Batman symbol, but take my word, it's a bat. But there is a possibility of an intermediate host. Having said that, there was a lot of rumors and sort of preprints that were shared. Someone looked at the receptors and had some speculation that it may have a snake intermediate host. And no matter what you guys do, don't call it a snake virus. There was a headline in the not in the Baltimore Sun, in the Scottish Sun. Baltimore Sun is a much better paper than the Scottish Sun. That had this snake flu headline. But obviously it got transmitted to humans, and what really concerned us was the well-established human-to-human transmission. Because when things come from, there's zoonosis, when there's a jumping of a virus or a pathogen from an animal host to a human, that happens with some frequency. But what really concerns us is when there's human-to-human transmission established. Just to give you a little bit of a big picture estimate, so one measure of transmittability is the so-called basic reproduction number. Some people call it basic reproductive number. That's not a preferable term. Basic reproduction number, meaning, so one way of conceptualizing it is that in a naive population where sort of everyone is susceptible to this infection, if there is one case introduced of this disease, on average, how many cases they would infect? So that's one simple way of understanding this, and this is a measure of transmittability. This is not the sole predictor of how big, how dangerous the outbreak will be, but it is an important measure. There's a lot of, there's some uncertainty about the magnitude of it, but we do know that it is not as transmittable as, let's say, measles, which is one of the most transmittable common disease, which has this R0 number of 12 to 15. In some outbreaks, it has been gone up to 17. Ebola had this number of 2. And this is the novel coronavirus is comparable to SARS. It's more than the flu. And so this is some perspective to keep in mind, with the caveat that our information is evolving. We certainly know a lot more about this virus than we knew a couple of weeks ago, but our understanding is evolving, and so keep that in mind. And this is a natural phenomenon in all outbreaks that are emerging. So what can we do? So I have thought about it a little bit in terms of the big picture policy response, and so the implicit focus will be the response, from an academic and research perspective for the rest of the panel. But one of the things, those of you who don't know, that the writers have very little control over the headlines. So there's separate editors who do the headlines. So my op-ed was a little bit more nuanced than the headline would suggest, but we certainly have certain, I certainly didn't go for a call and response kind of a framework. Are we ready? No. But we did talk about certain gaps. First of all, what I postulated was, and this was, I wrote this a few hours after the first case was identified, the government hadn't formulated its response. So some of us were concerned about the response being handled by the political leadership. Look, it's not an unreasonable thing to say that our elected leaders, who we elect in a democracy, could be at the helm of a major emergency. But this is slightly different, and it should vary from pathogen to pathogen and emergency to emergency. And here's the reason why. When you have an outbreak with substantial uncertainty, we should acknowledge that uncertainty, but the decision-making process should be structured in a way that the assimilation of ever-changing and ever-evolving information and the decision-making should be very proximal, and ideally led by the same set of people who have the detailed, nuanced knowledge intuitively of these things. They should be calling the shots. And who are those people? Fortunately, those in this country who are leading our major public health agencies, the NIH, the CDC, FDA, even the HHS, various entities within the HHS, are mainstream, well-respected scientists or public health professionals. And so rather than sort of having this outbreak, irrespective of the political perspective, in this kind of a situation, being handled at the White House level, for example, it would be best for the agency heads to tackle this. So similarly, let the scientists and public health professionals lead. But look, it is hard, it's highly unsatisfying. I was on an AMA Reddit like half an hour before I came here, where a lot of questions, it's easy to speculate, it's very tempting to say provide certainty. We certainly know a lot about this outbreak than before, but we owe it to the general public to convey what we don't know, but also what is knowable and what will never be known. And so therefore, yes, saying that what is happening right now, you shouldn't be walking around in a spacesuit on College Street, is reasonable to say that. But on the other hand, we don't know the future risk of this outbreak. We have some things to go by, and we'll flesh that out a little bit in more nuance. So don't provide false assurances. Don't alarm, certainly. And the other thing that has happened, as look, universities have a unique space in our society, which is we are the guardians of evidence. Lux et veritas is not an accident. And when we are guardians of evidence, we should think about not just what knowledge is being generated and how it's being implemented, but the quality of that evidence. And so the preprint server movement, where open science requires and nudges us to share our data and our academic output very quickly on these preprint servers without peer review, overall is a really positive development when it comes to speed of sharing knowledge, and can serve us really well. The genomes were posted very quickly and very robustly, in the sense that, in terms of the number, obviously in terms of proportion, there's a lag. But we should also be careful about how valid that information is. So one way to thread that needle, and there have been incidents that things have been retracted, even in the New England Journal. So it's not just the new preprint servers that have been vulnerable. There have been other things on preprint servers that have been revised, etc., and people have changed their perceptions around the outbreak based on that. So one proposal I discussed there is to have a pre-planned rapid peer review system that is already set up to evaluate information on a quick turnaround basis. I'm not going to go into the details right now, but just to remind you of the response, this is a public health emergency of international concern declared by the WHO. There have been travel restrictions, etc., and there have been quarantine, various measures akin to quarantine that have been implemented. We will discuss the merits and the value and certain nuances of these responses in a little while. These are a couple of things WHO recommends in terms of, preventive measures covering your mouth and nose when you're coughing and sneezing, using tissue into closed bin immediately after use, clean hand. Hand washing is a very important preventive measures. It's not the panacea who's going to take care of all our woes when it comes to respiratory disease, but it is something that you can do now. It is evidence-based, and this is something we can do now without any further technological development. And then there are certain recommendations, without going into details, on the WHO sites in terms of staying healthy while traveling. So I'll pause here, and I will then introduce our panelists one by one. But before I do that, I want to thank one of my postdocs who helped with some of those slides, Amin Malik, and I already thank Albert and others for helping organize this session. So the first, I'm going to call the panelists in alphabetical order. The first one is Ellen Foxman. She's an assistant professor of lab medicine and immunology at the Yale School of Medicine. Her research focuses on understanding the natural mechanisms that protect the airway from respiratory viruses. And you can see how that is relevant to what we are talking about right now. And one of the interesting things that she's working on is rapid diagnostics for these kinds of emerging diseases for mass screening. So that straddles individual and public health response, and that's one of my favorite kinds of responses. The second this panelist is Gregg Gonsalves. He's an assistant professor of epidemiology and associate adjunct professor of law at Yale Law School, and he's the co-director of the Yale Global Health Justice Partnership. So he has two homes, Yale School of Public Health and the law school. And he's a perfect example of an activist scientist. He's a solid activist, very passionate activist. He has the fire in the belly that we all felt in our first day of grad school, which has, some of us get jaded, others stay enthusiastic and passionate. And he's also a top-notch scientist and models impact of decisions and operations and using quantitative techniques, which are really fascinating. The third panelist is Nathan Grubaugh. He's also an assistant professor of epidemiology of microbial diseases at the Yale School of Public Health. And he has done some very interesting work on genetic epidemiology and has been co-curating with his colleagues these viral genomes that have been posted or has been shared, and creating this, if you will, the map of this genome as it evolved. And this is real-time public health that takes advantage of important, immediate information sharing and brings it together for hopefully decision-making and response to an emerging threat. Then we have Lisa Sanders. Dr. Sanders is a clinical educator in internal medicine, and she's a primary care provider and an Emmy award-winning producer of CBS News, as well as an author. And the other thing I like is, is that as a House fan, she was one of the, inspirations for House. Is that correct?
My column. Not
Yeah.
me personally.
Yeah.
I'm way nicer.
I can see. I was trying to look for the resemblance with Hugh Laurie, but
Sometimes I limp.
yeah. And then our last panelist is David Vlahov. He's the PhD program director and professor at the Yale School of Nursing. And then he also has a joint appointment with EPI here in the School of Public Health. He was involved, and he did some very fascinating work in early 2000 when SARS broke and anthrax happened, on the response of healthcare providers or the public health workforce, including school nurses, etc., who can be the tip of the spear of a mass response. And was involved from that perspective, but also as a professor of nursing has thought about and would provide his expertise on some of the healthcare and workforce decisions, etc. There are a couple of people who are in the audience who are not official panelists, but I may sort of put them on the spot. One is Dr. Paul Jennison. He's the director of Yale Health. So if there are any questions that come from that perspective, I will point to you. And Albert Koh, who's an overall smart person, but also involved with, has long-standing links with Chinese colleagues, but equally importantly, he's involved with a WHO working group developing interventions and evaluating interventions, more importantly, developing a common protocol so that we are not sort of have a different playbook for developing countermeasures against this outbreak. So with that, I'll switch to the question and answer phase of this forum. So my first question will be from Nate. So where did this virus come from? And I think our best bet to figure this out is not to send Hugh Laurie and investigate, but to look at the genetic data and look at other viruses, etc., that could tell something about that. Could you elaborate a little bit on that?
Yeah, sure, thank you. First, I'd just like to say that it's really great to see so many students in the audience, so many people that are interested from a lot of different backgrounds. So the question really gets at something that I'm very interested in with outbreaks, and that is misinformation. So if any of you are on Twitter or are reading some columns, maybe you see a lot of misinformation about the origins of this outbreak. First, I can tell you this is not a deliberate release from a laboratory. So some of the evidence that people present for that is a paper that did some, I'm going to say, shoddy analysis to say that there is elements within the coronavirus genome that had an uncanny resemblance to HIV, and therefore it was man-made and released from a lab that they say is, there's a high containment virology lab in Wuhan, which is actually perfect for being able to respond to these events, but then people are suggesting that the virus was man-made and came from this lab. That is absolutely not true. There's no evidence to actually say that, and the analysis was faulty. Where this actually came from is like with Saad's slide, is that the group of viruses that this virus belongs to are beta coronaviruses, and their ancient origins are in bats. There are some 200 different known species of beta coronaviruses in bats, and from what we know, there are 7 of these viruses that have spilled over into human populations to cause outbreaks. 4 of them cause common cold. They're right here in New Haven. 1 of them is SARS, 1 of them is MERS, and 1 of them is now this novel coronavirus. So the question really is then, looking at these genomes and looking at this data of when and where did this happen? So the when part of it, if we look at all the genetic data that we have, we can estimate that the origins of the outbreak was about early December, maybe late November. And there are some questions about whether this came directly from a live market that was in Wuhan. It's sort of uncertain if that is actually the case. The most epidemiological evidence would suggest that. But it certainly came from a mammal of sorts. So beta coronaviruses infect mammals. So this gets into another point of misinformation out there that maybe this was a snake virus, or maybe this actually spilled over from fish. But we don't know of any of these viruses that have ever infected anything other than mammals. So what exactly that intermediate host was, if there was an intermediate host before we had a human outbreak, is sort of unknown.
So that brings me to the question about the viral pathogenesis. So Ellen, do you mind elaborating a little bit on that part of how the virus affects our cells and us as humans?
Yeah, sure. Hello, everyone. It's great to be here. My lab studies respiratory viruses, and there's a lot of those, as we're all familiar with the common cold and the flu and these viruses that we get year after year. And so I thought I'd talk about this virus in the context of that. What are similarities and what are some differences? So as many of you probably know, the way a virus causes illness is it is able to enter a cell or several cells of your body and hijack those cells and basically turn those cells into factories for making more virus, which can be damaging to the cells. And also, but then your immune system realizes that's happening and comes to that area of the body to fight the virus and get rid of it. And wherever that battle is going on is where you get the symptoms. So if you get the common cold virus in your nose, the immune system's fighting it in your nose, you get the symptoms of the runny nose and so forth. If that battle's going on in the lungs, then you're going to get lung symptoms, breathing problems and whatnot, the things that we associate with pneumonia. So this virus can do both of those things. It can infect the nose or it can infect the lungs or both. So you might ask, well, why are we more concerned about this than we get these viruses every year? They're going on in New Haven right now. We've got lots of other respiratory viruses. And the main thing is the fact that it's new to the human population. So as I'm sure many of you are also familiar with, is the idea that when our body fights a virus, there's a memory immune response that's formed that makes it so that if we see a virus, that virus or a similar virus again, our body is much better at blocking it before it even gets into cells. So that's always the concern about a new virus, is that none of us have that pre-existing immune defense up and going. And that makes it potentially easier for the virus to spread from person to person. And also if it gets into your body, you don't have that first line of defense that could maybe prevent disease as well as if you had seen the virus before. And that's why like a new virus is always a cause to be alert, it's a cause to be vigilant. Just because it's new doesn't mean it's worse than other viruses that we know, that we're familiar with. But it means there's a potential, and that's why there's a reason for the heightened vigilance about it.
So that's a very important point to remember, that just because it's new doesn't necessarily mean it's worse, unless it's a disaster movie. But in real life, that's not the case.
We just don't know a lot of those things yet.
Yeah, exactly. And so Lisa, you're a primary care doc, and tell us a little bit about what preventive measures we can take now, and perhaps if the outbreak expands in the community.
Well, it seems now we all know what to do, hand washing and, coughing into your elbow and things like that. Not probably getting too close to people who have obvious infections, giving them their space, since this is probably passed through fomites or other kinds of respiratory-borne particles. So I don't think there's anything particularly wild that we can do. I'm not sure that, certainly if you had a cold, perhaps it might help if you wore a mask, but certainly there's no evidence that wearing a mask is going to keep you from getting it, nor does there seem like there are very many people who have it now to get it from. So I think having ordinary levels of precaution makes sense. I mean, I assure you, most people don't wash their hands nearly enough. So if people just wash their hands just a little bit more, it would probably go a long way.
Yeah, that's certainly in line with CDC recommendations, and specifically, at least at this point, CDC doesn't recommend wearing face masks. It's probably, perhaps, one of the reasons people wear them is for self-efficacy. They want to feel in charge. So it's a situation of helplessness when there is a lot of uncertainty. So perhaps those of us who, or those of you who work on health behavior and communications, perhaps we should have a message of self-efficacy in the form of saying, you can wash hands, which is not going to take care of everything. You can practice some level of social distancing without being paranoid about this, especially when you have someone infected. Social distancing doesn't mean that you start discriminating against people willy-nilly. It means that if you have someone, you are specifically in that kind of a situation, you take care of, you take some of these precautions. Now, so from individual prevention to public health response, David, do you have any thoughts in terms of the response at the mass level and some of the things that you were involved with earlier on, in previous similar outbreaks? And the second part of that question of some of the things that have been employed by various countries, including China, including the US, and some of the others.
Here you go, sir.
Oh, okay. Well, thank you for the question. In terms of what's going on in China, there's quite a bit of discussion about whether quarantine makes things better or makes things worse. And the idea of having people that are separated and protected seems like it would be a good idea, but it also has a stigmatizing effect where people can underreport, go underground, if you will. And if we take the example of Ebola, which again is a very different, it's an analogy that doesn't work at a lot of levels, but again, just that stigma of being confined and not trusting in a particular environment, there's a lot of discomfort and anger and acting out that can happen with that. So it's what's the process that can be a middle ground? And the approach that I think seems better, although you have to look at what is the local situation, what are sort of cultural considerations that go with that, are to be able to have a conversation with people in terms of, what is your likelihood of having been exposed given what we know, and taking that person to have the individual responsibility, for staying at home, for example, right? Secluding oneself for a period of time, right? That's a social contract that happens. And, for many people that seems very reasonable. And there are going to be others that, may need a little bit more assistance in that area. So I think that's one of the larger issues that comes up and has certainly been in the news is, quarantine or cordon sanitaire, right? What are the different levels of protection one can have? Now another part of the question is what is a public health response? And Robin Gershon and Chris Qureshi were doing a study of nurse preparedness in New York City and found that if there was some sort of disaster that was about to happen, how many of you would have at least one barrier that would stop you from showing up to work or whatever? So it turns out it was 90%. I had child care, whatever, all those different issues. And then it was not by design, but the anthrax hit New York City, and they followed up and they found out that every single person, every single one of the nurses showed up to work and did what their job was, right? So part of it is, recognizing that people will rise up to what that challenge is, what their professional responsibilities are, and part of that also is, having the education and support to be able to do that. So I'll pause because I could keep going. I'll pause.
Yeah, no. So very insightful. So you mentioned quarantine, and Greg, I want to sort of switch to you. There was some really interesting work. I wasn't here in New Haven in the area at that time, but there was Ebola-related quarantine, as I understand, in the area. And even as an outsider, as someone who looks at these issues, I found Yale Law Schools and the Global Health Justice Partnership, some of the people who were involved in the Global Health Justice Partnership, collaborated with the ACLU on a report that came out of that experience, which is a very, very helpful, very pragmatic tool that a lot of public health practitioners should pay attention to. Could you elaborate in terms of if we quarantine, or whatever the parameters of quarantine should be, and if we do that, how should that look like?
So, if you were here in 2014, 2015, in wake of the Ebola epidemic in West Africa, several governors across the country decided to quarantine individuals returning from West Africa, healthcare workers, in absence of symptoms, confine them under quarantine, including 2 Yale students who were not infected with Ebola, and including a West African family from West Haven who were not infected with Ebola. This was done by former Governor Dan Malloy. We are still in a lawsuit. The law school's immigration clinic is partnering with us in a suit against the state of Connecticut against these quarantines, but we wrote a paper with the ACLU and Doctors Without Borders to talk about what would happen, the epidemiological and the legal implications of the Ebola quarantine on healthcare workers in the wake of the Ebola epidemic. And Dan Bausch, who was one of our EMD speakers 2 weeks ago, was one of the scientific advisors on that, and many people in this room helped out. We did, you can see the report on the GHJP website at the Yale Law School, but the back of the report has recommendations about what happens next time. Guess what? It's next time. A couple of things to remember. One is to use the least restrictive measures possible. so not to overreact. So in the case of the Ebola epidemic, the quarantines were absolutely unnecessary and justified. As David is saying, there may be self-isolation and staying at home if you feel sick, or quarantine if necessary, but it really to use the least restrictive measures for a start, rather than sort of going full steam ahead for quarantines. The other thing is to ensure robust procedural protections. You have rights under the U.S. Constitution to bodily autonomy and due process. And so, when our students were put into quarantine, we could have appealed their cases immediately to the courts, but it was a 14-day quarantine, and we ended up suing afterwards because the time period was too short. But you do have rights under the Constitution to due process. Casey Hickox, who was a nurse with MSF, who came back to the U.S. and was quarantined by Governor Christie, a Republican, in New Jersey. Her quarantine was overturned by a judge in Maine who said it was epidemiologically unjustified. So in one case, the law worked out. The other thing is ensure humane conditions of confinement. Now, I saw on the news today that China is thinking about quarantining or taking all the infected people in Wuhan and other places and putting them into quarantine camps. What are the conditions going to be like for them? Are they going to get adequate health care? Is there going to be adequate infection control? We're thinking about the risks to us here in the United States, but think of the thousands of Chinese patients with coronavirus now whose health status is going to be put into a precarious position if they're isolated in these facilities that we have no idea who's overseeing their quality and their ability to prevent onward transmission from these sites. So there's lots of things we can do. I'm not going to go through all the recommendations, but follow the science, as Saad said, follow the evidence. If you hear the word abundance of caution, beware, because it means like, damn the evidence and we're going to do what we want to do. And that's what Governor Daniel Malloy, Governor Chris Christie, and Governor Andrew Cuomo did in 2014 and 2015, which was bipartisan stupidity.
On that note of bipartisan kumbaya, I guess. So I want to switch to a lot of those decisions were made in a communications environment, in a public, in a milieu of an interesting, to say the least, public discourse. So Lisa, as someone who has been involved as an author, as a producer, obviously as a physician on top of all of this, what do you think, what is your initial impression of what is happening now? What are some of the nuances? What are some of the adequacies? And what are the things that we should have learned from previously that we could do better?
Well, I don't know how accurate a representation of the country Twitter is, but you don't have to look very deep in Twitter to start seeing real crazy about this proliferate. And to some degree, I think that's completely natural because of the disconnect between the messaging that we have. You're much more at risk of the flu. Just wash your hands. Don't worry about it. It's going to be okay. Versus closing the country off to people from different countries who've been to China, imposing quarantine, sending people to concentration camps when they're diseased. I mean, that suggests a level of concern that doesn't really match what we're told to do, right? So we're told to calm down, and yet everybody in the government seems to be extremely excited. And nobody's really trying to make that connection. And when you have big gaps like that, it's inevitable that crazy creeps in. Because people are worried, and that's how people express it. I think that we need to acknowledge that we have to try to make sure that nothing bad happens, while saying the risk right now seems limited, and acknowledge that we don't know what the future holds. I mean, I think that those are the reasonable steps, but this kind of poo-pooing concern, of course, makes everybody crazy and really worried. And I think it's completely natural. As journalists, of course, we need the snappy headline. it's essential. I mean, maybe the New York Times doesn't need a snappy headline. Oh, although I think they have been tempted by that once or twice. But certainly other publications need that. Television needs that. You know, I mean, this is a competitive environment. So some of that is understandable. I don't know that it's forgivable. But as public health people, we have to step in and try to make it make sense to the people around us. We can't depend on the media necessarily to do it.
So the front line of this response in this country, because of the way certain powers are given to the state and local health departments, a lot of people don't realize that yes, CDC provides technical guidance, but actual action in terms of outbreak prevention and control on the ground happens at the state and local health departments. Over the past 20 years, there has been a lot of investment. The investments in terms of resources have stalled. Should we be reassured in one way by the head start we have had since SARS and anthrax and the 2009 pandemic, or should we be concerned because of the cuts that the public health system has seen over the last at least 6-7 years? So any thoughts on that, David?
I'm not sure, except, how best to start on that. It's a crisis like this that can be a stimulus to get the public health funding. I mean, we certainly saw that in earlier crises. It may be delayed, but I think there's an opportunity here to say we've got to take the public health preparedness very seriously and to generate the resources to be able to respond to this.
But doesn't that sort of usually vanish after, like, sort of we get this bolus, this sugar rush of investment in global health, and then we have this 7 years of crankiness after that sugar rush dies down in terms of where we, the public health system, after building up, having this surge, then suffers from these consequences. Any thoughts on a sustainable way of investing in public health this way? I know Sten, the environment had a very good op-ed in terms of the global health investments and not having these boom-bust cycles and sustaining the infrastructure. But domestically speaking, sort of any thoughts on how to maintain that infrastructure that doesn't go through these cycles? Sten, do you want to contribute?
The reality is that public health is faced with an inherent challenge. It's hard to convince policymakers to pay you to do something to prevent something from happening. It's much more intuitive to invest in hospitals to care for the ill than it is in public health infrastructure to prevent the illness to begin with. So that is part of the theme, I think, this evening of all the panelists, that we're up against tremendous communications challenges. How do we advocate for infrastructures for disease prevention, for rapid response, to be prepared for something that might or might not happen? And there are so many compelling demands. In a developing country, you advocate for public health, and you're up against the Minister of Defense, you're up against the Minister of Tourism, you're up against the Minister of Education. Where we have more resources in high-income settings, it's almost equally challenging. The NIH budget is in the neighborhood of $33 billion a year, and the CDC budget is a fifth that. So people understand disease, research to treat disease, tremendous investments in clinical trials. The prevention budget is far more modest. So I think it's part of our duty here in the School of Public Health to work more diligently on how to communicate with lay audiences about public health and prevention, how to communicate with policymakers so that they appreciate that an ounce of prevention is worth a pound of cure, which I suspect our grandmothers told us. And at the end of the day, integrating acute care settings with chronic care maintenance, as with the HIV investments in Africa, where a tunnel vision approach that these are for HIV, and nothing but HIV, when people may be dying of untreated hypertension, where there may be an Ebola virus epidemic around the corner in which those infrastructures could be helpful, a coronavirus epidemic. I think we need to be broader in our thinking, less siloed, and more attentive to how infrastructures can be pluripotent. They can serve a function today for an investment today, but keeping in mind that there may be an investment in the near future for which these infrastructures can be highly valued. Ultimately, that's a challenge we're facing. I know that the Bloomberg philanthropies are investing in precisely that, with Tom Friedman's initiative in New York City, and the whole philosophy of that initiative is chronic disease care, upgrading that care globally, but having each chronic disease investment be prepared for acute responses to outbreaks. And I think that's a very wise philosophy.
No, that's a really good point. In terms of coming back to a little bit of more science, and one of the misconceptions, one of the more frequent questions some of us get asked by the press is this virus mutating? And it's such a general question. I'm not going to go into the details of why is that a sort of a non-specific question, because we have someone who knows a lot more about it than I do. So Nate, would you like to elaborate on the various layers of that question?
So this is one of my favorite topics of misinformation during outbreaks, and the answer is, of course, it's mutating. But I'll go back a second. So mutations sort of conjure up these inherent fears of something unexpected and some like major change. Think of American pop culture, X-Men, right? These mutant humans have these extraordinary abilities. You think about if you ever read a Andromeda Strain or watched the movie Outbreak, as soon as a mutation is introduced into the picture, something new has happened. So, of course, the people that grew up on this, when you hear the word mutation, right, this is what you're thinking about. You're thinking about these crazy changes that can happen, not about the the fundamental evolutionary processes. So every time a virus replicates, when it copies its genome, on average about one mutation is introduced. And most of these mutations don't do anything to the virus. Some of them make the virus worse than they're lost, and some of them provide a benefit. But what we're actually thinking about, I think, when people ask about mutations, are actually natural selection. So are these viruses becoming better adapted at something? So I think it's a perfectly reasonable question to ask, is this novel coronavirus adapting to humans? So during the Ebola epidemic in West Africa, we found that early on in the outbreak, there's a mutation that appeared, and through a lot of experiments and everything, we found that it eventually dominated the outbreak, and it looked to be a human adaptation. But when we look at the epidemiological evidence of the people that are infected with this mutation or with not, there wasn't a difference in the death rates. There wasn't a difference in how much virus you had. It was a human adaptation that didn't really have a major epidemiological impact. The same with SARS. SARS, after it was introduced, we found these changes that happened that looked like they were human adaptations. But when you look back at the data, you can't actually determine if this had any major impact on the overall epidemic. So could this novel coronavirus adapt better to infect humans? Sure, it possibly could. Will it have a major impact on the epidemic? Will it cause more deaths? There's not really any evidence to suggest that.
So the last question of this phase before I open up is from Ellen, and I want you to talk a little bit about diagnostics. So our ability to detect this, and especially from the perspective of, we in global health hospitals, always think about inequities. And for example, in Africa, one of the questions is that the fact that we haven't detected, a lot of cases is because, is it the absence of the virus or the absence of detection, et cetera. So could you talk a little bit about our ability to have these diagnostics and its implications for an equitable response through knowing the burden and the our ability from a scientific perspective to detect these viruses in populations?
Okay, sure. So one thing that was really quite amazing about this outbreak compared to other ones is how quickly the actual genome sequence of the virus was online. It took about a week. I mean, it was amazing. And so advance in technology, like the advance in we all know that it's much easier to sequence genes than it used to be. But this is really a great example of that, where as soon as the outbreak was recognized, that scientists were able to actually, right from the patient sample, get the whole sequence of the virus. In the past, you had to try to grow it, and there was many steps. And that was really an example of the application of a pretty expensive technology, actually, but in a way that's going to benefit a lot of people very quickly. As far as diagnostic tests, so that's discovery. That's virus discovery, and this has really been quite like a poster child for an amazing infrastructure for virus discovery. And then as far as diagnostics, having that genome sequence online immediately, the way that we detect viruses, here in our hospital right here at Yale is often by doing a detection of a snippet of the genome, and having that genome sequence that quickly means you can quickly make a diagnostic test, which the CDC has done. But then the other issue comes of if you do a diagnostic test enough times on a population that doesn't have the disease, you're going to get some false positive. Any positive would be a false positive. So right now what's happening is there's a lot of criteria before people will be tested, by the CDC, that they actually have a chance of having the virus before they will be tested in the US. As far as around the world, I mean, these kinds of tests are not super cheap. Like these PCR-based tests, it's a little bit complicated. You need a special machine. You need people who are trained to perform the test. And so for all those reasons, it's not like something that you can quickly and cheaply get out to tons of people. So there are a lot of efforts now to say, how can we use our new technologies that we know that we have now, that we're developing, on a research scale, to make cheap, quick tests that could be distributed and could allow people to be diagnosed more widely.
So before I open up for questions, I just want to remind everyone that outbreaks, be it the plague in Europe or in the 1918 flu pandemic, a more recent Ebola outbreak, etc., can bring the best and the worst out of people. It's extremely important for us to treat each other with dignity and respect and compassion. Dignity and respect and tolerance is somewhat passive ways of looking at the world. And in my short time at Yale, I think I can fairly say with some confidence, this is not a passive community. So it also demands that we are active in our compassion for our peers, for our students. And not just when the outbreak is in China, but when we have a scenario that your mom or uncle or a cousin from Colorado calls and says, there's this, I've heard this thing on Twitter, and there is that tone of concern and fear that is part of that conversation. So as part of the Yale community, it is our responsibility to, in these kinds of situations, I'm not saying that this is going to happen. Uncertainty doesn't mean that it's going to explode. It means that it could go, it could go on the other side as well. But if it does happen, my hope is that all of us will look back on this year as part of the Yale community, most of us who are here, and we will be proud of our response as a group of people. So let's just remember that before I open this. And I have no doubt that it's not going to happen. Absolutely going to happen. But my hope is that we go one step beyond that. We bring the same passion and compassion and lack of passivity to this as we bring to the other parts of our endeavors at this campus. So there is a microphone somewhere. Yes, so there are a couple of microphones on either side. So please, ask your question, state your name, etc. And if you have an affiliation, one way or another, if you're comfortable, please state that as well. Please raise your hands.
Hi, Mark Russi, Yale School of Medicine, and also doing analysis. In 2003, there was a lot of discussion about the phenomenon of super spreading, the Amoy Gardens outbreak in Hong Kong, the index patient at the Metropole Hotel. Are you seeing, and perhaps this is a question for Nathan and Ellen, are you seeing anything either potentially ascribable to host factors or to some combination of low levels of humidity, unidirectional airflow, etc., that leads you to believe that there are cases where there's a substantial excursion from the R naught that we're seeing of about 2.5 with this disease?
I will start by saying I don't really know the answer to your question. The only thing that comes to mind is this. There was a report that in several Chinese media outlets that they tested environmental samples at that Wuhan market, and there was a good number of them tested positive for the virus. So, so that suggests that at least at that market there was a spot where there was a lot of this virus. Why that was is not clear, but there was a spot where there was a lot of this virus. Was it from an individual who was shedding it? Was it from, an animal? Was it, I don't know the answer to that, but that's the only thing that I can think of that I've read about or heard about that would suggest what you're talking about. I don't really know the answer to that with regards to I have not heard of any reports of super spreaders or anything like that at this point. I don't know if anyone else might know.
So do you want to say something? All right. So there's a question at the back. The right-hand side.
Hello, Lee from School of Management. So I got 2 questions. The first is, is there any scientific way to measure the quality of the data published by Chinese officials? And the second question is, hypothetically, if the initial outbreak is happening in New York, which has the closest resemblance to Wuhan in terms of population and mobility, and if the public health official was notified 2 weeks after the initial outbreak, how things would be handled differently?
So Nate, you have thought a little bit about sort of information quality around this outbreak. Do you have any thoughts to contribute to on this?
Start it now. I can check in.
I'm sorry?
I said you can go ahead and start it.
So I can start. So that's a really good question. So we don't have a direct, sophisticated way of saying that what a given paper is saying is valid, other than we do have tools. There are tools that have been with us and have served us overall well, but not perfectly, for decades, if not centuries. And that the most effective tool is called peer review. And that's where someone else who's not involved with this whole process says, look, there's something odd about this. And then they they question, they push back, and if the responses are not satisfactory, then sometimes the paper doesn't get published, etc. So that has changed. We're in a very different communications environment now, scientific communications environment, in this kind of a situation. The results of these products, intellectual products, are being shared on Twitter. Before they're even submitted, they're on preprint servers, etc., which is okay, which is overall sharing the viral genome quickly and publishing that has a lot of value. I think we'll have to complement that with a rapid standing peer-reviewed system that looks at that and says, we are going to perform, you have posted it on a preprint server, the preprint server flags it, sends it out to this group that has signed contracts, maybe pay them to have this commitment, say, I'm going to turn around, because there's a finite types of people that you would need in an emerging pathogen kind of a situation. You would need epidemiologists, you would need virologists, you would need a few clinicians who would pay attention to these kinds of things. So you can have them on a retainer in future situations where you say that this paper is submitted to this preprint server, we evaluate quickly, and we say, does that make sense or not? Before, while the information is still out there, we give it a stamp of approval or otherwise. So that would be a way to do that. And any other thoughts, Nate?
Yeah, I'll just say something on the quality of the data that's coming out. So one thing that's really important to keep in mind here is the sheer number of cases that are being reported today, now into like the 3,000s. Those are at least than 3,000 tests that are being performed today, and probably not all of them are positive. So you got to think about, so some of it may, the quality, it may not really reflect what is happening. I don't think it has anything to do with the quality of the reporting per se, right? It's just like, how many tests can you actually do in some of these places every day to get that information out? So there's going to be an underreporting that's happening that isn't necessarily deliberate by any means, but it's just sort of a function of overloading systems, right?
I mean, the only thing we can say is that data sharing is important at this moment. That whoever has data needs to share it at a global scale among the scientific communities, because it's not just what you see in the publication that's important. It's the raw data that people can run reanalyses on, and there's some question about whether all the data is being shared in sort of a transparent way at the current moment.
That's a very important point.
One more comment about the preprint servers, though. It is quite amazing. Nate talked about that sort of wrong analysis showing the misconcluding about the HIV present in the coronavirus genome. But I have to say that went up on a preprint server. Many scientists read it. Many scientists commented about it and said this is a problem. And the authors took it down and apologized. Yeah. And that all happened like within a few days. So actually, in a way, the system is, there is sort of this informal peer review going on. Likewise with the New England Journal article that was retracted. So there is sort of an informal process that's kind of coming out of our global connectivity, which is sort of encouraging.
So I'm generally a glass 10% full kind of person. It's always something to be hopeful about. With this exception, having worked in vaccines, I've interacted with the fever swamps of 4chan, where these conspiracies live and thrive and multiply. And my concern is, even after all the retractions, some of that stuff will find a life of its own. But it is, there is always these kinds of things have trade-offs. I think having access to, especially raw data, but also some of the analysis quickly, my tentative judgment is it's a net positive. And a net positive, not by a sort of a close margin, but substantially. But it has had, to quote Batman, actually Spider-Man, with great power comes great responsibility. Voltaire said it, but he probably didn't say it wearing tights. So with the power of sharing that information, it is our responsibility to guard the veracity and the quality of that information through the full scientific process.
I can talk without that. Lei Chen.
So we have broadcasting. So
okay, so I will wait.
Yeah.
There was the person in the back that was there.
Should I wait? Lei Chen, School of Medicine, Department of Pediatrics. I have a question about seemingly the difference in mortality between Wuhan patients and those outside. Do you think that's simply a question of not knowing the denominator of how many people are really sick outside of Wuhan, or is something specific about the environment?
So, Albert, do you have any thoughts on that?
No, go ahead. I don't know.
The mic right there.
Yeah, so I think, of course the numbers coming out of Wuhan are very concerning, especially because of the number of deaths and the proportion of deaths. But this is kind of very much like many epidemics that have occurred at the epicenter. The cases which were identified were primarily severe cases, and you can tell by the age, the average age was around 60 for the cases that were reported. If you compare that to what we're seeing among travelers or evacuees that are being identified, we're seeing that all ages, and many of them are having mild symptoms. So this is probably, as you're suspecting, we call it case ascertainment bias, in that many of the cases in the initial part of the epidemic were more severe.
So I'm going to come back to the question that was asked, that there was a two-part question, and one of them was what would happen if something like this was reported in New York City. And I think that's an important question, and we should keep it in mind before we criticize other country, be it in Africa or in Asia or wherever. in terms of what would happen, both in terms of, it's a good counterfactual, both positive and negative as well. So any thoughts on that?
Well, in New York City, you have quite a bit of history, and it's also a major. In New York City, I think there's a greater preparedness based on, a history and certainly a recent history of events that have happened. So there's memory, if you will, and preparedness that goes along. I think the second part is that the information and decision making is much more decentralized, and so that decisions can be made much faster than what's being reported overseas. So again, how much preparedness is there, the experience with it, what's the level of decision making? I think those would be three of the bigger buckets, and we could probably flesh that out more.
So we are fortunate to have folks from the health department or experience with health departments. So as the mic goes there, I want to talk to Paul a little bit. Dr. Jennison, any thoughts about hospital preparedness in this kind of a situation?
For Yale.
For Yale.
Yeah, well, first just to say that the hospital, the hospital is full, and the capacity for surge is a real question. We have a fairly elaborate preparedness plan, including the capacity to set up a field hospital at the Landman Center at the gym in the case of need, but a concern about how we would be able to respond to a large number of people with serious illnesses is a real one. And I guess I would say that there's a balance on one hand between trying to manage anxiety and concern, which is predominantly what we're dealing with now, over against the issues of what would really happen in the event of an outbreak. And then just speaking to one point that you made a little bit tangential about self-efficacy and the need that people have to feel like they're doing something. Anyone who hasn't had the flu shot should please get one.
Sure. I'm Drew Hadler. I'm a former Connecticut State epidemiologist. For the last 11 years, I've been working in the emerging infections program here, but also as a consultant to the New York City Health Department. So I think from a control perspective, I can't say what the reaction would have been. But I think from the information gathering perspective, it would have been much, much more focused, and the information would be out there, a lot of the information that we need. So for example, I was there when pandemic flu hit in 2009 in New York City. Had a huge high school outbreak that was one of the seeds for the city, where 4 or 5 kids came back from their vacation in Cancun. Turned out they had H1N1. They went to the same high school, and within 2 weeks there were 900 cases in that high school, and then family members, at least that many family members. That was a fair amount of resources went into that. It was fully described. Transmission issues were described. Spectrum of disease within that context was described. The city also set up surveillance for hospitalized cases of H1N1 right away because they didn't have it going on before, and quickly had counts and could monitor what was going on. They also had mortality surveillance, and so within a month we had a full spectrum of. We had really good information to say that H1N1 was no more variable in a sense than any seasonal influenza we knew that was affecting children more than older adults, which was subsequently there were good explanations for that, because older adults, people in their 50s and older, 40s or 50s and older, actually it turned out did have some immunity to H1N1 and weren't quite as severely as affected as younger people. But basically, we could put it in perspective and then base control measures on that. Again, I don't know what the immediate control measures would be with this, but there would have been surveillance set up that would have attempted to define the full spectrum of the disease, how severe it was, and CDC would be invited in as it was then. There's actually a number of CDC people stationed in the New York City Health Department anyway, and so there would be a lot of communication with CDC, daily conference calls with jurisdictions around the country to explain what would be happening in New York City was the main one that was affected, and we have the information we need to try to have a rational response to it and not one that's sort of all guesswork.
There's someone in the back.
Thank you. Actually, School of Public Health, Environmental Health. So my question is about the large number of patients. So since the outbreak, a large number of patients with mild or severe, no matter mild or severe, they rushed to the hospitals. So I believe the number is like more than 10 times more than the hospital can feed. So my question is, so will you recommend people with mild symptoms not to go to hospital and just to stay at home?
So I'll do you have? I can start the response, and if anyone has anything to add, Paul, if you have any thoughts on that. So this is very important. So at the big public health response level, in an emerging situation, having clear evidence-based communication is extremely important. So talking to people that at certain stage of the outbreak and response, certain kinds of symptoms need to stay home. For the abundance of caution in terms of individual response, often may require, if there is a judicious use, is to sort of self-isolate without sort of disrupting the overall functions of a society in that sense. But also, so Dr. Jennison Paul mentioned something very important, getting your flu shot. And the reason why we say it's not biological, flu shot doesn't protect against the coronavirus, but it does protect against a major respiratory illness. So it helps in two ways. First of all, it has its own benefits in terms of reducing morbidity and mortality in several age groups. But also it reduces, if you are reducing symptoms of respiratory illness in a population, then unnecessary visits that were not caused by coronavirus go down. And so, again, we are not helpless, passive spectators to something that is unfolding. We have inherent self-efficacy in the form of, for example, hand washing, which is evidence-based measure for all respiratory illness, all-cause respiratory illness, flu shot, and some of the other measures. Do you want to say something more, Paul or Albert? Any thoughts on this?
No, I think that's very important. Also, just to decrease, the less likely influenza is in the community, the more likely it is to be able to assess people with respiratory infection quickly and efficiently in the event that we do have an outbreak of coronavirus.
It's an interesting point. I did a study a while back looking at if you have syndromic surveillance in New York City looking for outbreaks, can you immunize people enough so that you have greater specificity? And the challenge of getting enough people immunized is there. So from a population perspective and concept, I think it's great. But that could also add to the case that we want to make is that that's another reason why we should be encouraging immunization.
Yes, there's a question there.
Patrick from the Department of Environmental Health Sciences. So as a Chinese, all my family is living in China and my friends sharing all this information every day. So one question we're all wondering is, when will this end? So I think a critical question is, when do you expect the turning point will be? Some experts say we have an incubation period of like 2 weeks, and since the quarantine or the whole Wuhan city and a lot of quarantine measures have been taken, there's roughly like 10 days or 2 weeks already passed. So if you're doing some modeling or forecasting, so when do you expect this turning point will show?
I'll just start with something basic on this. So just based on one model that I've seen, and I don't know necessarily if this is going to be the most accurate prediction, but it was looking like mid to late February would be like the peak. But there's a lot of things that can happen between now and then that would even change those estimates. And then you have to wonder, the data that this is all based on. So I don't know if we have a really great handle on this is going to be peaking and when it's going to start coming down.
And without providing false assurances, I think it's reasonable to share experience with other coronaviruses, especially SARS, that there does seem to be a seasonality associated with those viruses, and that seem to be more transmissible, using the term loosely in this kind of a situation. The peaks are higher in terms of in winter. So there is, again, tentative hope that some of those months will have a positive impact. But again, it's tentative. We are dealing with, I would be providing false assurances by providing some certainty around that.
I think the fairest thing is to say we don't know. During the Ebola outbreak, there were multiple mathematical models that predicted wide sort of trajectory to the epidemic. So I think information is trickling out to parameterize these models. So until we have more data, until we have more sort of examination of how these parameter estimates were put together, I think the safest thing is to say we don't know.
I talked with Alex Langmuir, who was the founder of the Epidemiologic Intelligence Service. And the one thing that we used in class was FAR, right? FAR's law. And it's the first law of epidemics, which is whatever goes up must come down. So, we don't know where that point is.
Did you say that you sort of talked to Langmuir himself?
We talked together.
Oh, so you talked together, okay.
Yeah.
So you were a professor at the age of 12, I guess.
He was at
I'm Jerry Freeland from the School of Medicine and School of Health. So one of the real unusual characteristics of this is how rapidly it spread globally. And in a month's period of time, this is 20-some-odd countries in very different parts of the world because of a sort of fortunate time in which this occurred and people traveling. So I wonder what we know about the response in other places. We're, of course, most concerned about what happens here and what happens in the U.S., but this is a global epidemic now of some magnitude we don't really know. And the response is going to be different in different places, and that's going to have consequences, actually, for the global nature of this and recurrence and things into the future. So is there any coordination on an international level at this point? Can we somehow or other advocate for this if it's not going on in a way that's actually functional and important? And the information coming from other places will be very, very important in terms of what we understand and how we can respond.
Albert,
Albert, do you want to add something?
This is being videotaped. Well, so the politically correct answer is that, of course, there is coordination, and that coordination is being done by WHO on many different levels in terms of outbreak response, in terms of training capacity, and so forth. But we all know the situation with WHO has been essentially neutered because of the lack of multilateral funding. Much of the funding is bilateral, and which has really incapacitated some of the effective responses and coordination. So I'm being a little bit harsh on that, but I think that is a gap, and that's why we have this myriad of bilateral responses, which are potentially not well coordinated. And I think the concern, and I'm just going to jump on to what Kai said and others, is that, this is, I think we're still in the exponential phase of the epidemic in many of the cities of those 5 million people who left Wuhan before. We don't know the exact proportion of who's been affected, but I think it's fair to say in Suzhou province and Shanghai and Guangdong, we're in the exponential phase. And that delay of model, which has been modeled 3 days, may be much longer. So I think we're in for the long term. And I think the big question is that in places that have weaker surveillance systems, and I'm thinking about Southeast Asia or South Asia, in India there's only 3 cases, but how many kits are available? And so forth. So the concern is this, I'm going to go all the way to back in the beginning with what Nate said, is that this is probably one of 7 pandemics or so, coronavirus. I think it would be good to be optimistic and be good to think that we can push this into a season of low transmission. But I think we have to plan on this being, spreading, and not necessarily peaking early. And I think we also have to plan on what's going to happen in the most vulnerable populations of the world, and what happens when it gets there. And this is a case fatality rate that may not be as high as MERS or SARS, but it's not going to be negligible either.
It's going to be heterogeneous in different parts of the world, seasonal.
So I want to go back to a question that was asked earlier about the people with mild infection going to the hospital. And I think that a lot of that could be prevented if we had a very good sense of what the natural history of this disease was and what it looked like when it was bad. Like, does it start off mild and become bad? That's one disease pattern. Or does it start off bad and stay bad? If it starts off bad and stays bad, then if you got a mild case, then you shouldn't go to the hospital. But until we know what that is, until we can describe it and make that public, people, of course, are going to go to the hospital with even the mildest symptoms because, of course, they're worried, and rightfully so, perhaps. But I think that that's one of the pieces of information that we really need to get out to people is what does it look like when it happens? Like, is it bad all the time? Or does it start off mild and get bad? That's an important distinction.
So in the interest of time, I want to finish on time. I'll take only a couple of more questions. And there were a few questions on this side. We spent some time on this side for a while. So you had a question for a while. And then there was one more in there. So unfortunately, we'll have to stop here. I'll be happy to stay back. And maybe others will also come around for a while.
I'm Paul Jennison from the Department of Laboratory Medicine and Immunobiology. I was wondering, you mentioned 7 of these coronaviruses, some causing cold, and yet some, like SARS, hit a lot of lethality. Do we know biologically what is different about the SARS versus the ones that cause colds that causes this lethality, and can we use that information when we're studying mutations in this current coronavirus to predict potentially what might be more of a problem?
I can start on that one. Well, one interesting thing is there's a coronavirus. The coronaviruses that circulate, every year in New Haven and throughout the U.S. sometimes cause colds, and they can cause serious illness, particularly in people who have other health conditions, kind of like what we've seen a little bit with this virus too. As far as the receptor the virus uses to enter cells, this virus uses the same receptor as SARS and same receptor as a different coronavirus that causes colds. So that's not the key thing. With SARS, there was some information about it suppressing the antiviral response pretty well, which you could imagine would allow the virus to get to a higher level in the body. But as far as this virus, I really don't know. So it's interesting, like the people have studied already where those receptors are found. What the receptor the virus uses to get into cells. They're in the upper airway, they're in the lower airway where the gas exchange occurs in the lung, and also on other tissues of the body, like in the liver and the blood vessels and things like that. So, but as far as, I think there still needs to be more work on the pathogenesis of this one to figure out exactly. It's not totally clear, kind of getting back to something that was said earlier, is at the beginning when a lot of people who are presenting to a hospital are very, very sick, a lot of those initial people were also people with other medical conditions who you might expect to get ill, more ill than somebody who's perfectly healthy and young. So it's still not totally clear, how that factors into the pathogenesis we're seeing and the mortality rates too.
Really quick so we can go to the next question. So it does seem to be if the virus can use the ACE2 receptor, it can infect humans. If it cannot use it, then it can't infect humans. That's one of the parts of it. But like whether this is going to be SARS or a common cold, we can't just look at the genome and sort of gaze at it yet. And we don't have the tools or enough data to say like how bad is this going to be. We're just, that's not quite possible.
So there was another question from there, or that has been answered by?
It's over here.
So I'll come to Evelyn, and then I think we have, I said one more, sort of time for one more question, etc. So Evelyn, do you want to?
Michael, can we do this question and then Evelyn?
Okay.
Okay, so I know China just finished building a 1,000-person hospital isolation ward. What do y'all think? Is this an efficient way to contain the outbreak, or are we going to end up with more issues than we started with?
I'm curious about the construction and the quality and the resources that go into that, the supplies that are available, what's the access. Really don't have enough information about the specifics, but I am going to turn it over to Gregg, who does.
No, but that's not the point. The point is that we can't abandon our Chinese brothers and sisters and say let them do what. The point is that the conditions of confinement have to be clinically suitable and meet human rights norms. And if they're being dumped in a hospital with poor infection control and without sufficient clinical capacity to take care of people, it's not the right thing to do. And we all have friends in this room and have friends in China, and we need information to get out so that people are taken care of both in their communities and in any facilities that might be sent to.
Hi, Evelyn Shea from the School of Medicine and Public Health. I actually wanted to follow up on Gary's question and hear from Albert. When you said there are myriad bilateral, initiatives, is that countries with China? I'm curious to know sort of the degree to which, there's been partnership with China, whether it's CDC or government, or, and how effective that has been, or, how much are they doing this on their own domestically? How much is their engagement? It's a little bit hard to tell from the outside. So. And I think this goes along with what Gregg was saying. To what degree is there? You can.
So I'd very much like Sten or David to answer this question.
My authority is my friends in China on WeChat who've been flagging up my phone all week. And it does seem like the Chinese are pretty much on their own on this one. There isn't any substantial international health infrastructure in Hubei province in Wuhan City. The US CDC has a presence in Beijing, but I'm going to guess that there isn't a coronavirus control expert in the group. But they do have good, solid epidemiologists, and it's not improbable that there's communication with the China CDC. China CDC is a pretty sophisticated operation. They have a sort of a command center for outbreak investigations that I visited that reminded me of the CDC command center and was modeled after it. And I am thinking that the Chinese are largely tackling this on their own. I have no evidence to the contrary, and my friends at WHO are not deeply engaged. I know people high up in the State Department that I've talked to, and they're helping the Chinese, but they're helping them from Geneva and from Atlanta. So I think there's a lot of communication, a lot of consultation, but on the ground, the Chinese are handling this on their own. I think that's fair to say.
Can I just?
Yeah.
Sorry, just to follow up, if this, is helpful at all, but I was in Beijing recently, and I was speaking to a documentary filmmaker about a film she made about emerging epidemics, and she was focusing on the Ebola virus. But when she was in Africa, she said that the best, makeshift hospitals that she had encountered were the ones built from China. So I think that if that's reassuring, that's great infrastructure-wise. But I understand,
Just put things in perspective, and I think there's a lot of issues coming around, freedom of information and disseminated information. But as Stan has said, the Chinese CDC is a very sophisticated organization, and and I think this is up to debate, and this is all speculation. But once the outbreak was shown, simply pull up policy reasons why it wasn't, the early warning system didn't work as it had worked with H7 and 9. They detected other emerging pathogens in the interim time between SARS now very efficiently. Why it didn't work now is unclear, and that's something that I think we really don't have a good answer. But once they had detected it, and once it went into the early warning from IHR, they followed all the IHR regulations, very sophisticated responses. They sequenced the genome. They are now doing many, randomized controlled trials for treatments. Many of those are probably going to come out with information in the next 1 or 2 weeks about how to cure it. So very sophisticated responses on many, on many. So I think we have to just put this all kind of in perspective.
Yeah, so I'll wrap up. I want to wrap up exactly at 7. I know there are other questions, and that's an indication of the importance of the issue and the engagement. So I'll be happy to stay back. I can't speak for other people, but I'll stay back if you have other questions, etc. But I want to wrap up. As we wrap up, first I want to thank colleagues who put it together and helped to organize on a quick notice. I'm not going to go through I wouldn't be able to go through the full list, but specifically Roz and Alyssa and Mike Skonechny and Jen and many others from different parts of, and Colin and others from YSPH and YGH, etc., who made this possible at a very short notice. But I will wrap up. As I wrap up, I want you to remember the intensity of response mounted by health workers, both clinical workers, but also public health workers in China as we speak. They keep all of us safe. They stand up, they rise up, they have risen up to the challenge, set aside all the politics. Individual health workers and the health system and the folks on the ground have responded not just on the behalf of their own community, but on behalf of us. And if there was any doubt of the sacrifice, we should remember that one of the physicians who was initial canary in the coal mine passed away. There are reports that he passed away. There were mixed reports, but I think it's now confirmed that he passed away today. On that somber note, we should also remember that we are not helpless observers. We have self-efficacy, both as humans, and as compassionate beings, and as scientists, public health professionals, academic, business executives, and so on and so forth. On that note, I want to thank you for coming here and being really engaged in the discussion. I appreciate that. Thanks.